Now, I want you to look to your right and look at the two people sitting to your right, and then look to your left and look to the one person sitting on your left. And 1 out of the 4 of you will unfortunately die from a heart attack. Heart attacks are the most common cause of death in the developed world. About 200 people die every year in the UK, and that's the equivalent of a 747 crashing every other day. Now, if you have a heart attack, God forbid, the likelihood of you surviving to hospital is actually less than 50%. But if you did get to hospital, the one thing that would determine your survival would be the speed with which you received your treatment. So anything that puts up a barrier to the speed of treatment actually costs lives. Now, a heart attack is caused by a complete blockage in one of the arteries or tubes that supply blood to heart muscle. So in this video on the left, we have a 48-year-old man who's in the throes of having a heart attack. And about 40 years ago, there was very little that could be done. You were given morphine and put to bed, and you spent several weeks in hospital, and you often had complications from your heart attack. Now, for many years after that, we gave clot-busting drugs, and in many parts of the world, this is still the treatment given for patients with heart attacks. And those clot-busting drugs break down the clot that's blocking off the artery, but it only works in about 50% of people. And patients still spent a week in hospital and had complications afterwards. Now there is a very up-to-date, high-technology treatment for heart attacks, and that's called primary angioplasty, or immediate angioplasty. And what we do is, under local anesthetic, so we have a heart attack patient who's completely awake, we put a little tube into the groin, or now typically the wrist, and we pass a little tube up to the heart, and we obtain what's called an angiogram. And doing that, we identify the blocked coronary artery. And we then pass a little wire through the tube, through the artery, and we open up the artery with a balloon. We suck out some clot in some cases, and then we put a metal scaffolding tube called a stent to hold the artery open. So on the right side, you see a video of the same patient who's had a stent, and you now have blood flowing all the way down the right coronary artery. Okay, so this is a very effective treatment for patients with heart attacks. Patients spend 2 to 3 days in hospital, and the probability of them surviving to discharge is about 95%. But it's all very well having this treatment available. The key is being able to deliver it to as many people as possible. And now I want to share with you the jaw-dropping statistic, which I think is incredible. And that is that in England, we deliver this treatment to 99% of heart attack patients. And what's more important is that 24 hours a day, 7 days a week, the average time between the patient arriving at hospital and having the balloon inflated in their coronary artery is 41 minutes. So at the heart attack center that I work at, we have an average door-to-balloon time of 30 minutes, and that's for all heart attack patients, regardless of what time of the day they arrive. So I think that's a very impressive statistic. Now, how did we come to this point? Now, all journeys of innovation start with interesting characters, and this is Dr. Werner Forssmann, who was a German junior doctor, who came up with the idea that you could put a tube into somebody's arm and pass that tube through a blood vessel and get it to the heart. Unfortunately, his seniors did not support this idea, and so he had to persuade an assistant nurse to help him set up the procedure room. He tied the nurse then to the bed so that she wouldn't interfere with his experiment, and he passed a urinary catheter, which is quite a large tube, up his own arm, and then walked to the radiology department and took that X-ray of the tube in his own heart. So this was the first ever cardiac catheterization performed on a human subject. He lost his job, unsurprisingly, but he did win the Nobel Prize in 1956. And then in 1967, this amazing man, Melvin Judkins, who was a Californian family physician who then became a radiologist, he developed the technique of coronary angiography, and he invented these pre-shaped catheters that you see him holding here. But what was really remarkable is that he did not patent this invention. He wanted it to spread as quickly as possible and be as widely available as possible throughout the world. And so he made very little money from it, but we've all gained from that sacrifice that he made. And then on the right, we have Andreas Grunzig, who was the Swiss radiologist who performed the first ever balloon angioplasty on a young man with a partially blocked artery. So he did that procedure in Zurich in 1977. He then went to the States, where the Mayo Clinic greeted him. He made a lot of money, he bought an airplane, and unfortunately, a few years later, died in a plane crash. So there are many individuals who've contributed to this journey of innovation. Monorail catheters that we use all the time in the cath lab now were developed at Stanford University, where I did my Fulbright. There are multi-billion-dollar companies building these finely engineered scaffolding stents that we use to open up the blocked arteries. But for me, the key innovation in delivering this technology to everyone has been the existence of a national healthcare platform, a platform that guarantees universal care, and I'm talking about the National Health Service that we have in the United Kingdom. So we have a service, a healthcare platform, which puts patients before profit, where collaboration between organizations and different aspects of the healthcare system trumps competition mostly, and I don't use the pun lightly, and barriers to healthcare are kept to an absolute minimum. So I think this is one of the key things that has allowed us to develop this technique. And so you can see in this graph that over the space of about 5 or 6 years, we've been able to go from the old-fashioned clot-busting drug treatments to the high-technology primary angioplasty treatments. Now, when I was a Fulbright at Stanford, which was 15 years ago now, I did come to realize the value of our universal healthcare system here. A couple of stories that I will now relate to you. One was that a friend who developed chest pain was called for help and put into the back of an ambulance, and while he was writhing with pain in the back of the ambulance, he was told that because he didn't have healthcare coverage or health insurance, he would have to pay an extra $200 if he wanted to have the sirens on for the ambulance. And on another occasion, I was asked to attend to the mother of a friend of mine. She had a history of high blood pressure, but because of the cost of medication and the fear of possible costs if she went to see her doctor, she hadn't actually seen her primary care physician for 3 years. And as a result of that, her blood pressure had spiraled out of control, and she had had a stroke on that morning in question. So these were two experiences in the US that persuaded me that the NHS is actually something extremely valuable. So going back to how we've developed this healthcare heart attack program in the UK and the NHS, the 3 key features for me that have allowed us to do this. The first is that we have rolled this out in a coordinated fashion throughout the country. So we started off with a few pilot centers doing pilot studies to demonstrate the value of the technique, and now we have 52 heart attack centers throughout the country, evenly spread, which deliver this service 24 hours a day, 7 days a week, and I now work at one of those centers. The second thing is the recognition that no single hospital is an island, and that no one part of this healthcare system works in complete isolation. So the ambulance crews work with the hospitals, who work with the GPs and the community rehabilitation teams. It's all part of one big coordinated effort to help the patient. Now, contrast that with a story that I heard from Texas recently, where a heart attack patient was transferred from one hospital to another hospital on the same street by helicopter, because it wasn't clear who would pay for an ambulance transfer. So in the United States, at the moment, the main cause for personal bankruptcy is the cost of healthcare. And most of those people who go bankrupt actually have healthcare insurance, because the people who don't have healthcare insurance, like my friend's mother, don't even seek medical care. And there's some evidence out of Johns Hopkins that if you're uninsured in the States, your risk of dying from a heart attack is 30% higher than if you do have insurance. So it makes a huge difference to people. And the third point that I wanted to make is that in the UK we have complete transparency of data. So all the data on outcomes and performance statistics for individual operators, including myself, heart attack centres, and how we compare with each other is all available on the internet in the public domain. So you could Google me and you can find out how many angioplasties I've done, what my performance has been like, how many emergency angioplasties, and so on. All that data is out there for public scrutiny, which is incredible. So, in a brave new world, I do think that technology will bring us better treatments. It will also hopefully reduce the barriers to healthcare and treatment in the future. But the key thing for me, and the key thing about innovation in healthcare, is going to be being able to bring those technologies to as many people as possible, not just the select few. So we want a healthcare system where patients are put before profit, where we collaborate rather than compete. And I think we already have that in the UK. It's an extremely valuable resource. I do think that industry, the private sector, and the public sector will collaborate in the future, but I think that the NHS should be firmly in the driving seat of that change. Now, as we all know, and for those of you who have been here for a short period, the NHS is under severe threat at the moment. The critics of the NHS say that it is too big to innovate, that it isn't agile enough to change, and that we have to disrupt our current healthcare system in order to make progress. Well, I would suggest that the way in which we've delivered heart attack care in the UK counters all those arguments, and that regardless of our political persuasions, what we should be doing is fighting to save the NHS, preserving this very unique healthcare system which will allow us to deliver these highly advanced treatments to as many people as possible. So to the many, not just to the few. And I think we should try and obstruct those who try and dismantle the NHS in the name of so-called progress.